Thank you, Dr. Suma ma'am and Dr. Meenakshi ma'am and AIOC for allowing me to speak on infantile esotropia. It refers to an inward deviation of eyes, usually presents with a large deviation. If you look at our own number of esotropia OPD patients were 916 and we operated 598 for esotropia, but out of that only 336 were having esotropia presented with the complaint of esotropia within 6 months of age, but not they didn't present even before 1 year, because we are in a rural area. They don't present at that age, infant age. Usually it is non-accommodative esotropia, large esotropia. There are many theories are there. Worth, Shevas and Havelston all are saying different etiology for the esotropia, but infantile esotropia, it may be associated with conditions like amblyopia that you need to take care. And if it is small baby, you can just see that she's allowing right eye, but she's not allowing left eye for occlusion. So at early as possible, you need to check for amblyopia. We have got lot many things to treat amblyopia first. Initially, in these babies, we have to give iPad, but now people are moving from iPad to iPad. So there are many exercises available. Small to moderate hypermetropia can be associated with infantile esotropia, can be latent nystagmus, can be associated with dissociated vertical deviation that needs to be taken care, and apparent limitation of abduction just due to cross fixation, sometimes absence or reduced binocular vision. Risk factors are prematurity, family history, perinatal complications, genetic factors. Clinical features usually large deviation between 30 to 70 prisms of diameter, usually presents with triad of IO overaction, dissociated vertical deviation, and latent nystagmus elicited by occluding either eye. Clinical evaluation to be done, including AC by A ratio, but in infant it's very difficult, but from visual acuity to fundus examination. This baby presented to us keeping the chin down position always, and we just made her to look straight, and what we see is large esotropia. So this baby was inferior oblique overaction, V pattern esotropia. Differential diagnosis for infantile esotropia can be simple pseudoesotropia, which is just epiblepharon, or apicanthal fold, which can be easily detected to parents by pulling just nasal bridge, and it is ortho. Can be purely accommodative esotropia, the eyes are straight after wearing glasses, can be congenital fibrotic syndrome, can be Duane's type 1 retraction syndrome. This baby presented to us with esotropia and sometime esotropia and sometime not moving eye, but the father gave complete history that in morning she opens the eye like this. So after allowing to do acetylcholine test, which was negative, still we insisted to go for neostigmine test in this baby. This is 6 years, and immediately after neostigmine she can move the eye. Yet another baby, small, she also presented with loss of movements with presence of anesthetic, when with all parameters we just gave within 1, 2, 3 minutes, and she opened complete eye, and then she started moving the eyes. So that was a ocular myasthenia. Moebius syndrome or congenital malformations, lateral rectus palsy or nystagmus blockage syndrome can be there, which can be easily just detected by doll's eye phenomena. So child's right eye is moving laterally, but left eye is not moving. So we can do with same with the infant. I couldn't get good video for that. Esotropia secondary to other neurological disorders or simple mechanical esotropia. This is retinoblastoma or lipodermoid, which is pushing the eye in. Management usually to restore binocular vision if patient presents within the 3 to 6 months. Surgical method for strabismus is still gold standard by lateral medial rectus recession, and again usually they may be presented with eye overaction. This is simple MR recession surgery, which I will not show, but my mentor Dr. Sargent used to teach me that in infants you should measure from the limbus. That works better than just measuring from the insertion. In IO recession also, sometime you have to do take care all the fibers of IO you are hooking in your muscle and save LR while cutting. So you can place near LR. This is the same baby presented Treatment of cross fixation usually will be done, but you need to follow up. In our area, patient may present at this age with the complaint. We can't leave this patient, just treat for cosmetic correction. Alternatively, so many surgeries, SR recession and other IO weakening are there, or sometimes you have to do, when there is SO overaction, we can do SO surgeries also. Follow up, look for amblyopia, consecutive exotropia, residual esotropia, and there are one-nodal outcome groups. Complications can be complication of treatment, that can be consecutive exotropia. Patient may lose follow-up and they come at exotropia with later age. So you need to take care, you need to treat that. Sometimes patient presents with adduction defects. So this was a medial ductal slip in its sheath. So that also you need to take care. Scar at the site of surgery, epithelial inclusion cyst at the site of surgery, or suture granuloma can be a complication. So what is ideal? The child keeps the head straight with good binocular single vision, with good stereopsis, without any pattern. And you can't leave the child in this small age. You need to follow up to the later age also. So in conclusion, there are two critical periods, 0 to 9 months and later on 6 years. Remember the cricket in this world, rule of cricket 4s and 6s, 4 to 6 weeks, congenital cataract 4 to 6 months, infantile esotropia, and 4 to 6 years, intermittent exotropia and nystagmus, etc. The early intervention gives good binocular vision and even good stereopsis. One should not overlook partial accommodative esotropia while treating infantile esotropia in order to prevent consecutive exotropia. So proper refraction, cycloplegic refraction is must to differentiate between accommodative esotropia and infantile esotropia. Thanks to my patients, thanks to my teachers, thank you.
I think Dr. Sabreen is not there.
She always shows good cases.
Yeah. Yeah. Thank you.
Fantastic presentation.
For the audience, any questions from the non-pediatric, the non-strabismologist?
So what do you do after picking up a DRS?
Okay. After picking up a DRS.
Syndrome, what do you do after picking
I thought our topic was infantile.
up? She shows up DRS cases.
Because it is a differential diagnosis, you should not miss, and you have to include all the movements when the patient is presenting with the complaint of congenital DRS. So what you want to ask me, DRS treatment, DRS 1, 2, 3.
No, I think what we should all remember is that how to, when a child presents with esotropia, should we, I mean, what is that case exactly? Whether it's an infantile esotropia, whether it's a early onset accommodative esotropia, whether it's DRS. So for that, I think what first and foremost you will have to do is an atropine refraction, any case, and then you see for the ocular movements. What she suggested, the doll's eye head maneuver may be helpful to rule out an infantile esotropia from a DRS. Okay. Now if you have a 6th nerve palsy, it is rare. But if there is a limitation of abduction and you want to rule out whether it's a DRS or a 6th nerve palsy, then again what you would do is that now you can't do a small baby, you can't do a forced duction test. So maybe MRI would be helpful to find out whether the 6th nerve nucleus is present or not. And other thing is that you have lid abnormalities. Of course, the lid retraction, the globe retraction in a very small baby like a 6 months or 8 month baby is not very characteristic. You do not get those classical palpable fissure abnormalities when the child presents to you at 6 to 8 months. But what you can do is that you can initially, there is a limitation of abduction. Congenital 6th nerve is rare. You can do an MRI and rule out whether there is a nucleus present or not. And then you can patch the eye, you do an atropine refraction, patch the eye and wait for some time. And then maybe after 1 or 2 months, whether you still, again when the child is still more cooperative, you again do whether there is any, like you can try under anesthesia whether you can try the forced duction test or not. So Duane's, if as early, so the Duane's treatment, in fact, none of us operate so early for Duane's. Anybody operates early for Duane's? No. We operate at 2 or 3 years, we operate for Duane's. So the doll's head maneuver is the best to rule out whether there's any abduction deficit. So as she showed the video, very nice video. So
So coming just to your question, in a nutshell, if it's in straight gaze, in primary gaze, if there is no squint,
If there is no anomalous head posture, you observe. If anything abnormal, you send it to SHREYA.